resections. When you inspect the resection cavity with the ultrasound, you can see once you gain the sterility with the ultrasound, you can see a residual tumor, and you can go for that if it's like functionally resectable. Then you can also use it to plan your trajectory when the lesion is underneath healthy brain. Actually, in this case, this is already the screen of the navigation with the ultrasound integrated with the pre-op MRI, and you can see here how it's already how can we see with the MRI that it has been a brain shift, and the tumor that it was depicted here with the intraop navigation using the pre-op MRI is now in here. So you can detect the brain shift with the ultrasound. It also is also radiation free. It's kind of universal. You can find an ultrasound pretty much in every hospital, thanks to anesthesia team most of the times. The cost is quite low, and it's also very time effective because it doesn't increase the time of the procedure significantly. This is one case with the ultrasound that we can see exactly where this was a metastasis, and it was a very small, like a half centimeter metastasis, and we can see it perfectly here in the MRI, so we can localize it and see exactly where it is. And as all techniques, it has also disadvantages. In this case, it has a learning curve, right? So it's operator dependent, not just to be able to get the images, but also to interpret the images, right? Also, cases that has been previous has previous surgery or radiation therapy, it happens the same that happens with other image modalities such as the CT or the MRI. It's hard sometimes to distinguish between what is residual or recurrent tumor and what is radiation, necrosis, and all of this stuff, right? Also here, depending of the transducer and the array frequency, the penetration in depth may be not as good as we would like to. And for early stages of the surgery, because we have the bone, especially in adults, because the bone is thick, it will block the ultrasound and it won't allow us to see through it, right? So it won't help us to plan, for example, for the craniotomy. And then it has artifacts as well. Artifacts is it could be defined as it could be air, it could be blood, it could be anything that interferes with the quality of the image that we get. In this case, is blood, and you can see here how if we have blood on the surgical field, everything gets like a hypercoic, and we cannot see anything. Different modalities of ultrasound. There's like A, B, C. There's a M mode, but the most common ones is the A mode and the V mode. B mode, that is the one that we actually use. The V mode, what it does is it transforms the peak sounds of the A mode in a two-dimensional picture, and that's what we use, the V mode. Where is this? Okay, so there are different things that we have to. There are different things that we have to take into account when we're doing an ultrasound of the brain. Like you usually start with with 8 or 7 centimeters depth, so we can have a better understanding of the tumor and the surrounding intracranial structures. In this case, this is the tumor, and this is the skull base and the dura. And then once we wanted to focus on the tumor itself, we decrease the zoom or the depth to 4 to 5 centimeters, depending on how deep the lesion is. There are different things that we can play around. I don't know if I have them here. This is another one. One is the depth. That is not the same as the zoom. The zoom tool allows us to amplify a particular part of the picture. The depth is just the depth of the ultrasound waves. And the other thing is the gain. that is kind of the brightness of the picture. We can adjust that as well. If we increase the gain too much, it will be too shiny, too bright, and it will lose quality. That's the other thing. It's like the contrast of the between the structures of the MRI. And then, as you know, we can just have two planes because the craniotomies are small. We can just have two planes for any particular lesion or area that we wanted to see. We can just create an octagonal view between two planes. It can be either, in this case, posterior fossa. We can create an axial and a sagittal view, but we cannot create a coronal view from this point, right? But with these two, we can kind of get, see most of the tumor and kind of create a three-dimensional picture in our minds. There are some 3D ultrasounds that have been used in neurosurgery before, but there are not many of them. And there's also another modality, this with contrast, but there's also like I haven't read about them, but I haven't seen like a actual machine. And this is like a view of some of the most common structures. You can see like how the dura and the false cerebri looks hypercoic. The plexus, it looks also hyper. The blood vessels looks also hypercoic. The ependyma is very well seen here. It also is hypercoic, and the ventricles and the liquid in general is hypoechoic. The sulci is also hyper, and the corpus callosum, it has like is slightly more hypo than the rest of the brain. And this is the aspect of some of the most common tumors in the brain. You want to take a guess of what they are?
So it's very heterogeneously.
Each one is different.
Oh, okay. It's like,
Yeah, each one is different.
Question. Okay, so I'm gonna guess that A. So A is pretty like homoechoic. It's like pretty like well circumscribed. So I'm guessing it's probably something like a meningioma.
Mm-hmm.
Also, just where is it location-wise with respect to the rest of the brain?
Oh, it's right. It's
Like,
extraxial. Yeah,
because the probe right is at the top.
Mm-hmm. Right. So it's panning down.
Right?
Yeah.
And it looks like you can kind of see that it probably looks extra axial. It's pushing the rest of the brain down.
Okay. Yeah, that makes a lot of sense. There's mass effect coming from above. Okay. And then
So that's the typical appearance of a meningioma.
Uh-huh.
Okay.
Okay. And then B. So B is a little more is deeper. Also pretty well circumscribed, but there's those areas of it's hypoechoic. Are those vessels that are penetrating through?
Those are cysts.
Cysts. Okay.
Or, well, they are actually necrosis areas. Yeah.
Okay. Okay. Well, then, that would probably say it's like some kind of glioma or GBM.
Yeah.
If it's a heterogeneous.
Yeah.
Okay. And then
Overall, well circumscribed intraparenchymal. Yeah.
Uh-huh.
With heterogeneous sort of size.
Yeah. So C is also interparenchymal, also pretty heterogeneous. But
these were actual cysts.
Oh, I see. Okay. It's like several cysts. It's not like a one large cyst.
What lesions is that?
Oh, yeah. What type of lesions create cystic cavities separate from the solid portion of the tumor, but it's not necrosis? I mean, there's several, but there are. I mean,
abscess,
there's
like an
one
abscess.
Category. Well, there's one big category that it could
I was just thinking an abscess, but
bigger, like still in the neoplasm category, like one giant category. Metastasis in general could do that, right? And then,
Okay. Okay.
but then you have specific other ones, right? You have also there are specific types of tumors that are more likely to cause cystic metastases compared to other ones. You know what I mean?
Mhm.
I can't remember off the top of my head, but there are. But there, if you know,
One
like,
more.
yeah, I think like renal and a few others, you know, tend to have more.
This was an adenocarcinoma of the lung.
Oh, from the lung. Okay.
Yeah.
There was also a couple CNS tumors that will also
Yeah.
cause cystic type ones.
Mm-hmm.
Yeah.
What about
The
pilocystic? What is it called? The
juvenile polycystic astrocytoma.
yeah, would that look also like that or
Yeah,
no?
yeah, usually though I think though like the CNS ones that cause like cysts, it's not as like kind of trabeculated like this. They're usually kind of
Yeah.
a small little nodule, like a nodule, and then a giant.
More
Neural
benign.
nodule.
Yeah. They usually look more benign. It's like just one solid.
One solid.
Yeah.
Yeah. Okay. Okay. And then D. Those vessels that are surrounding the
These are
The
sulci.
bright squiggly line.
Yeah.
What about?
sulci. Okay.
I mean, I'm guessing here, but what about the edges? The edges of this tumor?
Also pretty well defined.
Yeah, but like compared to like the other ones,
Yeah, not as much as the meningioma.
like if this was an MRI, what would you say it looks like?
Another metastasis?
Maybe. So it's kind of homogeneous. It's kind of feathery, maybe
Uh-huh.
the edges.
More like a primary sort of.
What kind of looks like a homogeneously enhancing sort of feathery lesion, say on like a contrast MRI? I don't know if that's what this is, but I would. That'd be my next guess as to what this is. Considering you already hit on like major categories, you're you know it can look like anything kind of, but somebody with HIV.
No.
No, it's not that.
Not that?
No.
Infectious?
Okay, no.
I was gonna guess lymphoma, but
I was
No.
gonna say could it be an MS plaque, but we really shouldn't be operating on
No.
that.
no, I was gonna guess lymphoma, but
Okay, so this is an oligodendroglioma.
There you
So
go.
they
That
have,
makes sense.
they have different. This is one of the lesions that have most diverse appearance. It can look like hyper or hypo, but this is pretty frequent to find, like a hyper lesion with no very well defined borders. Okay. And this is like, again, sort of like one case that we can see the
Cool.
transition between we have the preoperative MRI. This was the corticospinal tract, and this was the arcuate tract. And we can see how, playing with the window, we can go from this to the ultrasound, and it's pretty much the same. You can see pretty much the same structures, and the quality of the picture is very similar. You can also see the choroidal plexus in here. Okay. And this is like, let me see what is this. Okay. So this is basically a study that we did. I'm part of my PhD, and it's like what we did. It was, we have this station, and we did the pre-op tractography, and we did the segmentation and with the 3D reconstruction of the tumors. And you can see here how it looks again on intra-op picture, like the difference between the MRI and the ultrasound superimposed. This is the 3D segmented tumor. This is again this is the corticospinal tract, and this is the red one is the arcuate tract, and the red and the yellow is the tumor. So we did this study that is still like being written. We did a paper that has been published already, and we did this paper that is still in process. And well, we hypothesized that it was an effective technique to visualize the intraparenchymal tumors, and it will allow us to assess the surgical resection with high sensitivity and specificity, and also that it was safe and it did not increase the surgical time in a significant manner. We did publish the paper about time because there's like there are several papers that says how much the use of intraop MRI increases the time of a
Yeah.
surgery, which is
Totally.
from 20, 40 media to up to like 2 hours, depending on how many MRIs you want to get. If you have residual tumor and you want to get another MRI, and then you are not sure, and you can end up having multiple MRIs, and that can increase the surgical time up to 2 hours. But there was no paper saying how much actually increases the surgical time the use of intra ultrasound. So we did study that, and we did publish that. This was like a prospective study. We included about 80, almost 90 cases. They were all intra-axial tumors. The age was like the age that you will operate on, excluding pediatric patients, and they will all have the MRI pre-op and post-op with the navigation sequences. Pretty much that. And this is the equipment that we use. As you can see here, you have the Medtronic tracker, the same. This is specific for this transducer for the array, and this is the ultrasound that we use, the Sonosite. There are different types of probes. The one that we use the most in neurosurgery, and the one that we have here, is the convex array transducer, and it gives you this sort of picture that you can see here. And there's another one that is linear, that is called like commonly a hockey stick. That is this one here, and this one is actually more precise, but it doesn't have as much depth as the other ones, and it gives you a square rectangular image instead of this convex picture that you can see here. So this is actually the tip is narrow, so it's actually very useful when you want to, at the end of the case, when you want to assess for residual tumor, you can put it in the resection cavity, and we use it mostly for that at the end of the case. And this is basically how we prep. You have, of course, you have to you have your tracker, and you have the frame. We use the optical system, and what we did there is we put the conduction, the gel in a sterile. It was a sterile fashion, and then we cover the ultrasound probe and the stel with a sterile cover. And this is the screen of the ultrasound itself, and this is the screen of the navigation system, where you can see the pre-op MRI fused with the ultrasound. And we study a lot of different variables, blah, blah, blah. And then to measure the tumor, and we use the Stella station, and we then downloaded the pictures, and we use the Osiris program, and we did it in two different ways. We did it with this semi-automatic segmentation, like you will do, when we do the heads-up display and so forth, and that gives you volume. And then we use the formula of an ellipsoid, measuring the AP, medial lateral, and superior inferior diameters. That's one of the most accepted formulas in the literature. There are different ones that have been used for tumors, neurosurgical tumors. There's like the sphere formula, and there's another one I don't remember now, but this one is the most accepted one, and it's basically I haven't put it anywhere, but it's like you have the radius multiplied by 3/4 of the PE number. And this is how we measure the tumors with the ultrasound, because we didn't have a three-dimensional picture that we could use. We just used the ellipsoid formula, and we did it in the navigation stream. And same for the residual tumor. And this is a grading system that it has been described in the literature. It's actually the most comprehensive one that we have so far, and is the one that we use. When you look at the studies for intraop MRI or MRI in intra of ultrasound in neurosurgery, they kind of divide most of the times the tumors into good or poor or medium visibility, but they don't have like grades, and this is the only grading system that is available, and it kind of divides the tumor in grade 0, 1, 2, or 3, depending of if the lesion itself is visible, and also if the borders are or not clearly defined. So you go from grade 0, where the lesion is not visible, the borders, you cannot define them, to grade 3, where the lesion is well visualized and the borders are well defined. And this is an example of some grades. Here you can see this is the ultrasound, this is the MRI. This will be a grade 3 in both of them, because you can see the lesion, you can see the borders of the tumor. This would be a grade 3 on the MRI, because you can see the borders of the tumor and you can see the lesion, and this will be a grade 2 on the ultrasound, because you can see the lesion well, but there are some parts of the tumor that you cannot clearly define, right? And this would be a grade 3 on the ultrasound, and a grade 2 with the same amplification on the MRI, because you cannot see it was like a very small metastasis and you could not see it clearly. And then this is the sample that we have, 88 tumors, most of them, 83% were new. Most of them were located in non-eloquent areas, and most of them were GBMs, and 20% of them were metastases. And then we also, because we were measuring the tumors on the MRI with these two techniques, with the ellipsoid formula and also with the segmentation, and we were measuring the tumors on the ultrasound just with the ellipsoid formula, we wanted to see if actually the ellipsoid formula and the segmentation was kind of comparable. Mm-hmm. So with the volumes that we got on the MRI, with both formulas for each lesion, we compare them to see if it actually was something that was like similar or not, right? So this was the mean tumor volume with using the Osiris program with the MRI, and this was the mean tumor volume using the ellipsoid formula with the MRI. As you can see here, it was pretty much the same. And then we ran this statistic test, the Cronbach alpha coefficient, the ICC, and the Pearson coefficient, and they both all show that there was a significant correlation between both of them, and they were pretty much the same. It was very, these numbers, as close as get to 1, the more similar they are. And then when we did it with the ultrasound, we see again that the tumor, the mean volume, tumor volume that we got was 26.3. It was 24.9 with the MRI, so pretty similar. And again, all the coefficients and everything show that both tumor volumes, either if you do it with the MRI or with the ultrasound, they were pretty much the same. And it was the same pretty much for the residual tumors that we measured, same, pretty good coefficients. Same here. And then, that's something that I look at in the literature, if this has been described before, like what's the difference between measuring a tumor volume with the MRI and an ultrasound. And what I found is like there's very significant variations in the literature, both with the methodology that they use to measure the lesions, and also with the statistical tests that they use. Some of them said there was a difference between the mean tumor volumes with both techniques. Some, they say that there was a 7 centimeters on average smaller volumes with the ultrasound than with the MRI. And some say that it was a 1.3 on average larger tumors with the ultrasound and with the MRI. Yeah, and this study just compared percentage of one volume with the other. In terms of the visibility grade, we got with the MRI, 92% of the lesions were grade C and just 7 lesions were grade 2. With the ultrasound, we have 77% of the lesions with grade 3 and 22% of the lesions with grade 2. So that means that 100% of the lesions that we studied had a good visibility with the MRI, and 77% of them had clear borders as well. And the association between both techniques was significant. And this is the only lesion that we showed before that it had like a better visualization with the ultrasound than with the MRI. And it was like a metastasis of, I think it was a melanoma. It was a melanoma and it had blood in it. And then we studied some factors that could have impact the visibility grade with the ultrasound. The only two that were significant was like first versus second surgery. So meaning that the lesions that were not operated in before had a better visibility grade than the ones that had already undergone surgery, which was not was suspected. And then we also studied the immunohistochemistry and molecular profile of the tumors that we study just for the in glial type of tumors. We study the P53 and all the indexes and so forth that we had available, and the only one that was actually significant was the Ki67 index. We base this more than or less than 15% on a prior literature study that actually found that also the ones that have a lower index were better visualized because they were less aggressive. And then we actually had similar results, that the ones that had a lower Ki67 index had like a better visibility grade than the ones that have a higher index. And then again, in terms of visibility with the ultrasound, the results that we can find in the literature are very, very different. Some overall people say that metastases can be better visualized than gliomas, but it's not always the case. The radiotherapy and prior surgeries have a negative impact on the visualization, which is also something that we were expecting. And this is the study that I was mentioning before, that it says that the lower the index, the better visualization. And this is some results from some prior literature studies that haven't used the same grade system that we described. And we don't have to get into that. We don't have time. And then in terms of time, we studied the time that it took us first to covering the probe with the sterile drape, and it was actually 129 seconds. And then the time that we spent during the surgery using the ultrasound, and it was 149 seconds. So the total increase of the surgical time was about 4 minutes and a half. We used the ultrasound 2 times in 18 patients, and usually the most we used it was 4 times. That was our usual number, and sometimes 5 or more times in 20% of the patients. We can see here, as we start doing this with the first 10 patients, how the time that we use to spend to cover the ultrasound probe, it decreases with time, but the time that we use for taking the images, it didn't have a particular pattern. And then in terms of what impacted time that we were using the ultrasound, it was the insular location require more time than the rest of the tumor locations, most likely because of the complexity of the brain area. Second surgeries also require more, or it requires more time to visualize the lesion and to assess the borders. Laterality didn't have any impact. The type of lesion, low-grade gliomas require more time, and this is because the borders are not that well defined. As you know, like low-grade gliomas is like a diffuse disease, right? And then awake surgery also require more time. And when we run a multivariate analysis, all the variables remain significant, and the most important one was the insular location. So the location of the tumor was the one that actually increases the use time the most. We were able to find residual tumor in 19 cases with the ultrasound and in 21 cases with the post-op MRI. So we found that ultrasound actually has a great sensitivity and 100% specificity in terms of detecting residual tumor intraoperatively. So actually, in 8 cases that we thought that 11% of the cases that we thought that the resection was total, we took the ultrasound and we discovered that it was residual tumor, that it was actually resectable because it wasn't in an eloquent area, and we went and then we resected that tumor. So it has overall sensibility of 93% compared with a 65% sensibility if we just use the microscope with the navigation to detect residual tumors. And then if you look at the literature, the sensitivity for the ultrasound to detect residual tumor goes from 71 to 95%, depending on the studies, and the specificity from 60 to 100%. And pretty much all the studies says that the specificity in low-grade gliomas, well, this is tricky. So the studies available says that intraoperative ultrasound, there are several studies available that says that the intraoperative ultrasound has a higher specificity in low-grade gliomas than the MRI. But this is if you compare with intraoperative MRI, because most of the studies compare the results with the pre-op MRI, that is a 3 Teslas MRI. But if you compare with the available MRI that we have nowadays, that they don't have the same quality of image, actually the ultrasound for low-grade gliomas may be even better. And this is like a case that we thought that we have resected all, and then we found that it was this residual tumor with the MRI, and this is with the ultrasound, and this is how it looks. This small area here. And then because we use another techniques that we usually use, like awake surgery, intraoperative monitoring, and the 5LA. This is like Spanish and Catalan, yeah. So and Catalan as well, because we were asking the patient to speak in Spanish and in Catalan, right? So we also study if there were other variables that could have interfered with the results. And actually we use the 5LA in 28 high-grade gliomas, and we did the hold on with that we use the 5LA in 28 gliomas, and the degree of resection, total, subtotal, partial of biopsy, it was the same with both techniques. So it was comparable with the 5LA. And it showed us the same results in all patients, and it was comparable with the MRI in all cases but one, in which we thought with the 5LA and with the ultrasound that the resection was total. And then we could see this small rim or residual tumor with the post-op MRI. And then we compared the surgery with 5LA for high-grade gliomas with the patients that underwent surgery with a high-grade glioma without 5LA, and then we compared the resection rate, and we actually saw that the resection rate with and without 5LA was pretty significant. So we could say this is like a subgroup analysis, but that the use of 5LA did not impact the results significantly. And in extent of tumor resection, once again, we saw that both with the ultrasound and with the MRI, it was pretty comparable, pretty similar and significant. And this is again some literature about it. For low-grade gliomas, this study said there's like a good correspondence between both techniques, the intraoperative ultrasound and the MRI, comparing pre-op with post-op MRI. In this group, 87 lesions. This is the bigger group in the literature up to the study that we were running. It says that the concordance between both techniques is 78%. You see also every different study uses also different type of statistical analysis, so it's very hard to compare. This is where this study was just using the kappa test, and they were saying that there was almost a perfect agreement with 98%, and this used the pi coefficient. So
chi-square.
yeah. But overall, the use of intraoperative ultrasound has been associated in the literature with an increased percentage of surgical resection, which is important.
Is there any data or a number, unless I missed it, where the percentage of time in those that have used intraoperative ultrasound like routinely, like the percentage of time that they go and take out additional tumor based upon the ultrasound?
So, can you repeat? Sorry,
what percentage, like in those that use intraoperative ultrasound routinely in brain tumor resection cases, what percentage of time does the intraoperative ultrasound cause them to alter their surgical resection? In other words, cause them to go back to take out more tumor, or
yes. So in terms of time, there hasn't been any study that I look for it 2 years ago, and at least 2 years ago hasn't been any published study that actually measures the time.
Not the time, but the percentage of time, like the percentage of cases that like if I used intraoperative ultrasound every single case out of 100 cases, how many times out of those 100 cases did it alter what I was going to do? 20 times, 30 times, 80 times.
In terms of like if you will resect more tumor.
Yeah, exactly. Yeah.
I'm not sure. I know that in our case was like in 11%. Like if we have a sample of 88, and in 65 that the resection was considered it was complete. Eight of them had like 11% of the total sample has like 11%. It show us residual tumor, and it changed. So like you can say that in our case, almost in one of every 10 patients, we change our approach.
Okay. Yeah, that's kind of what I was implying.
Yeah. And then of course we didn't have any intraop complications associated with the use of intraoperative ultrasound. It actually, like you can argue that because it decreases sometimes even it doesn't increase the surgical time in a significant manner. And it actually, if you compare it with another techniques like the MRI, it kind of helps to decrease the surgical time. We have like a percentage of post-op complication that it was similar to the literature rates, comparing all type of like counting for DVT infections and all the complications that you usually count. And the mean follow-up on our study was like 16 months, and we have 3 losses of follow-up, but they were like GBMs, 1 after like a year and 2 after 6 months. And then well, the limitations of what I've been talking today and the study itself is again that the ultrasound, it depends of the person who's doing it, both to perform to acquire the images and also to interpret the images. But if you fuse the ultrasound with the pre-op MRI and you use the navigation, it will help you to interpret the image and also to orient it yourself, right? We did several things to avoid inter-observer variability, like the same person who was measuring the ultrasounds and the volumes of the tumors and also the grades of visibility was different than the one that was used doing it for the MRI. So we didn't have like a bias there. And it also, we didn't have the contrast enhanced ultrasound imaging that, as I said, is available for neurosurgery, but not many centers have it. And we were also comparing intraaxial tumors, but there were different types of intraaxial tumors, which allow us to compare them between them, but it adds heterogeneity to the sample, right? And also, even if the grading system for visibility that we use was the most refined that we have at the moment, it's kind of still very subjective sort of technique. But we also measure the volume of the tumors, and the extent of surgical resection will give us more accurate data. And overall, I think that we can conclude that, like also a part of common sense, that ultrasound is fast. It doesn't increase the surgical time in a significant manner. It's a safe technique because it's not, like related to any complications. The resection, the percentage of resection and the visibility grade and the volumes that we have calculated are pretty similar to those that we can compare with the MRI. And we have to keep in mind that most of the studies compare, again, the ultrasound with the pre-op MRI. That is like a 3 Teslas high quality MRI, not to the intra-op MRI, which usually give us a picture that is not comparable with the pre-op one. And again, it can be considered a real-time interpret images since it doesn't increase the surgical time, and also we can use it as many times as we want. And that's it.